Hello guys, I'm very sorry we're having some serious technical issues here, but I hope all is fine now. So welcome again to our first NoTube live chat dealing with tube dependency and prematurity. My name is Sabine Marinczek. I'm a clinical psychologist working with NoTube since 7 years and I'm looking forward to answer all your questions. Gerne können Sie Ihre Fragen auch in Deutsch oder Französisch stellen. Ich freue mich, mit Ihnen zum Thema Sondenabhängigkeit und Frühgeburtlichkeit und Essstörungen bei ehemaligen Frühgeborenen heute in dieser Stunde zu diskutieren. So, preterm born infants are at a high risk for developing tube dependency and eating behavior disorders. Es ist schon wieder.
Man sieht dich auch nicht. Oh doch, man sieht dich.
Okay, so I'm sorry, some technical issues. We're sorting that out. So children with who were born premature before the completed 37th week of gestation are at a high risk for developing severe feeding disorders or tube dependency. We treat many children who were born prematurely. Over 50% of all children we wean after feeding tubes have been born too early. And I'm looking forward to your questions.
Okay, 9 Leute sind dabei.
Okay. So this is the first question we got from Jan about our usual success rate for a 6-month-old to feed orally. Well, our overall success rate for complete weaning is over 90%. So more than 90% of all children we wean after feeding tubes are able to feed fully orally after completing our program. We have a very, very good outcome for very young children, so children under the age of 1 year, because they have not developed a mental tube dependence yet, so it is it is easier to wean them off the tube if they are medically stable. Time frame differs a bit. It depends on which program you undergo. So we have the net coaching option, which is a telemedical program, which has no time limit. So you will be guided by us until your child is tube free and 35 days after the last tube feed. And we have our eating school programs, which are 2-week on-site programs, but you also get aftercare via net coaching. But in fact, mostly a wean takes from 2 weeks up to 6 months. One cannot really say that in advance. It depends very much on your child and its medical history and its pre-existing oral skills. So I hope I could answer your question. There's another question from Christine. Yes, this is the place for the prematurity chat. Feel free to ask all your questions. James, yes, we are still live. I hope you can see that. Maud is asking, our team keep telling us about catch-up growth and risk of brain development during a wean. Okay, so our opinion on that. Of course, it is very important that a child grows adequately, but especially in preterm born infants who are born maybe even small or light for gestational age, in some cases catch-up growth can't be received even with full tube feeding. So brain development is not a linear development with weight gain. So if you gain weight, if you gain more weight, it doesn't mean that your brain develops better. So some children who are born small and light, stay small and light all their lives, but it doesn't influence their development in a negative way. There are some recent outcome studies of preterm born infants who are already adults. They are still a bit smaller than average, and their weight is lower than average adults have, but they have completely normal IQ. So my colleague Hannes Beckenbach, he did some developmental studies on children before and after tube weaning, and even though children lost a bit of weight, they made a real big step in all areas of development. So tube weaning even enhanced development, but did not harm the brain development of the child. I hope this answers your question, Maud. We treat a lot of children who have very low birth weight, from 400 grams to under 1 kilo. So we are very used to this specific population, and about 50% don't show catch-up growth anyway, even on full tube feeds. Okay. So if you have any further questions oder wenn Sie auch Fragen in Deutsch haben, können Sie diese jetzt gerne stellen. I think some people are still searching their way towards this chat. I hope everybody has arrived now. Maybe some facts about a recent study we have done on prematurity and tube dependency. So we found out that about more than 50% of all children on long-term feeding tubes are born prematurely, form a preemies. There are some hospitals worldwide who don't discharge children on feeding tubes, but others do. And some children stay on feeding tubes for many years or even for their whole childhood, although they have no other problems than the preterm birth. There's another question from Jan. Is a doctor usually involved locally to ensure safety? I think you're referring to our net coaching program, Jan. In this case, yes, it is necessary that you have one doctor who knows your child, who knows that you're undergoing the net coaching program, and who is willing to see you in case of illness or any other specific medical problems during the wean. But you don't need a doctor who is a professional for tube weaning. That's what we're here for. And of course, we won't take any risk for your child during the net coaching, so we will keep sure that the child is hydrated and not malnourished. Okay, Saira asks, can a child with development delay with respect to their motor skills successfully weaned? Well, generally, yes. So we have a lot of children who have developmental delays in different areas. Some of them have severe developmental delays, are not able to sit or crawl or anything. If a child is safe to feed orally, which means it doesn't aspirate and is able to swallow, then a child can be weaned. Of course, it depends very much on the individual medical history, and we do an assessment before every wean to tell you if your child is suitable. But in fact, developmental delays are no problem for tube weaning. So it's not a problem if your child isn't developed age appropriately. And especially regarding motor skills, it is not important that a child is able to sit or to stand for learning to eat, but of course it depends what the child is able to do in order of self-feeding. But weaning to thickened liquids or purees is already able for is possible for children with severe motoric delay. Hello, Laura. No, you haven't missed too much by now. Okay, so Christine, hello and thank you for your question. It's why do you think US programs do not have a great success rate? We kept being told she get it one day. Do you feel US programs should be more diligent in getting kids off tubes at a younger age? Well, that's answering this question is not so easy. I don't know why they are not having such a good success rate. I think many of the US programs are behaviorally orientated, so they work a lot with reward and punishment. That's not what we do. We want the children to enjoy eating. About being told that the child gets it one day, I know that that's not only a problem in the US. Some children stay on feeding tubes until school age because their parents have always been told, okay, one day they will eat. Unfortunately, in most children, this is not the case if they are fully tube fed, because the older they get, the more dependent they get on the feeding tube, not only in a physiological, but also in a psychological way. And children start to identify themselves with the feeding tubes. So, in fact, it gets harder to wean them. We promote doing a wean at the earliest possible age. Of course, the child must be medically stable before. But if it is, we would like to wean children as early as possible. So, yes, from my point of view, it would be great if one starts to try getting kids off their feeding tubes as soon as possible. Okay. Amanda, have you worked with children who have late dumping syndrome? Yes, we did. We have a lot of children with dumping syndrome who have undergone fundoplication surgery in order to prevent vomiting. Unfortunately, they develop dumping syndrome quite often, early or late dumping syndrome. And yes, we have worked with them and have quite good outcomes in treatment of children with dumping syndrome. Hello, Melody from Texas. Great to have you here. Laura asks, we haven't started weaning yet. Our boy won't swallow at all. And the doctors won't do a swallow test. Is there anything else we can request? Well, is he swallowing his saliva? That's an important first step, so we need to know that. They insist that he has nothing wrong. If a child is fully tube-fed, there mustn't be anything wrong with swallowing or digestion, but it can be simply the fact that the child is fully tube-fed, that it develops an oral aversion, or what we call tube dependency. So these children don't take anything by mouth, are not able to swallow anything. Some of them won't even touch food. So there mustn't be something wrong from a physiological point of view, but the children just got tube dependent. If your doctors think there is nothing wrong with the swallow of your child, I think you should go ahead with an assessment to rule out if your child is suitable for tube weaning. Jan asks, how long until the danger of becoming tube dependent from birth? Well, in some children this happens quite fast. Mostly it takes about 3 to 4 months for a child to get tube dependent. Of course, there are some who don't develop tube dependence this fast, but in some cases children are already fully tube dependent, stage 1 or 2 after 2 or 3 months on full tube feed. Hope this answers your question, Jan. Melody asks about NICU. I find part of the issue is the volume expected for the premature gut to digest, as well as the time elapsed between feedings often isn't sufficient. That's true. What do you suggest for initial tube weaning in NICU? Infant-driven feedings, less tube dependency. Well, I know this is not easy in NICU to feed children in the infant-driven way, because the nurses have to do their work and of course are not able to feed each child when it's hungry. But in fact, for children who are in NICU, it is important that they get discharged on oral feeds ad libitum, which means the child drinks when it is hungry. Of course, this can't be achieved within 3 or 4 days after the feeding tube has been removed, but it is important that the child learns to feed orally in a sufficient manner before it gets discharged. Planning this progress differs a lot between different neonatology units. So some units, as said, don't discharge children on feeding tubes, others do. So there's a lot of work to do for the neonatology units to get a state-of-the-art treatment for these children. We're currently working on that with different units, but of course there are still many, many different approaches. Laura, yes, we say to wean as early as possible. Of course, we have to know if your child is able to swallow safely. So this means he doesn't aspirate on any kind of food. We have weaned a lot of children with diaphragmatic hernia by now. You may also find some blog posts on our homepage regarding this issue. So you're welcome to ask us about this via email or in a free evaluation. But as soon as your child is medically able to eat and stable, we would like to help you in weaning your child. So in case you're not sure if your child is swallowing adequately, we recommend to do a barium swallow test or any test which is provided at your hospital in order to rule that out. Adam is asking if a child who isn't able to grab its own food, if it can be weaned. Yes, of course. children can be weaned even if they have no a hand-mouth activity. So they must be fed, of course, but this is not a problem. We can also wean a child on liquids and purees. And yes, we have worked with children with different mitochondrial diseases. Yes, we have done that already in some cases. Laura, if your child already ate well, then we can assume that he is able to swallow adequately, otherwise he wouldn't have eaten well by now. And if he stopped on full tube feedings, it's most likely tube dependency, which is holding him back from eating. But of course, we would have to get the whole medical story of your child for an assessment in order to rule out if weaning is a possibility. Hello Maria from Spain. She's telling us that her daughter Julia was weaned with by net coaching last year, and she's doing great. That's good to know. Yes, and she's telling you that you should never lose hope and trust your children. Exactly, that's what it is about. Very happy that your daughter is doing so well, Maria. Maybe something about the diaphragmatic hernia. We will also have a no-tube topic of the month for diaphragmatic hernia, I think in May. I'm not 100% sure about that. So there will also be a live chat on this topic during this year. Oh, it's in April, I'm sorry. So are there any other questions? Okay. Melody asks if we use modified barium swallow studies or FES to assess for aspiration. Yes, so we had both for our children. This depends very much what the local hospitals are going to do. Yeah. The problem with swallow studies is sometimes that the children don't cooperate, and this gives you a wrong result. So sometimes they simply aspirate because they are crying. So one always has to be very careful in interpretation of swallow studies, because it's not a nice situation for the children to undergo such a study. So it is very important to have a team who is experienced in doing these examinations in order to help the child stay calm. Otherwise, you simply get wrong results about aspiration, or that the child won't swallow. In some cases, this is simply related to the unnatural situation of the examination. Laura, okay, yeah, it seems that this also happened in your case, but as said, if your boy was already able to feed orally without any aspiration issues or frequent bronchitis, then he is most likely able to swallow adequately. So we don't need the swallow test for all children. This very much depends on their underlying medical condition. If a child was only born preterm but has no gastrointestinal issues or swallowing disorders, we don't need a swallow study in advance. So this very much depends on the medical history of the child. And if the child was already able to feed orally, because in this case one can assume that the child is safe to feed orally. There's another question. What does your team factor in when recommending that a child be net coached versus going to Graz? Okay, so in fact it's up to, in most cases the parents may decide if they want to come to Graz or do the net coaching, but there are some factors we want to let you keep in mind before you decide. We can't accept children for coming to Graz who have immunodeficiency, because they are in a group of children, and if they aren't, if they catch every virus, it won't be good for them. So children who are undergoing chemotherapy or something like that, we would like to treat via net coaching. Some children need a hands-on approach, so they need, the parents need training in how to feed the child. In this case, it's better to come to the eating school in Graz. In fact, also the eating school program is a combined program with net coaching. So even if you come to Graz for 2 weeks, you also get aftercare via our net coaching, as long as your child needs to get tube weaned. Hello James. London is currently in our net coaching program. And he's asking if they started the program too late, because the child won't drink. At any point, do you consider what the American medical community call failure to thrive and stop the wean? Well, failure to thrive is a term which is used for many infants who are below third percentile for age. This can have many reasons. So some children don't like to drink pure liquid because it's simply hard from a technical point of view, but this is not a reason why a wean wouldn't succeed. So most children learn to drink, but there are even some children who can't drink pure liquids and always need thickened liquid due to brain injuries or something like that. So this is not a thing which hinders the wean. Failure to thrive is a term, as said, for children who grow below the third percentile. Some children are naturally small. That's completely normal. Stopping a wean due to failure to thrive, no. In some cases, we would interrupt the wean and let the child gain some weight before we progress, but this is not stopping the wean. So we don't discharge a child just because it is not fast enough, or from our point not fast enough, or has lost too much weight. In this case, we will find a solution and maybe make a break or give some additional tube feeds until the child is doing better, or maybe only liquid by tube. But the most important thing is patience and trusting the child that it will learn these things in its own speed. So Laura has asked that she has been told by the surgeon that diaphragmatic hernia will cause no symptoms. No symptoms, is that true? Which symptoms do you mean? Maybe you can specify your question. Jamila is writing, we have tried everything but still is afraid about eating. Have you already undergone a medically supervised weaning? Would be my question. Melody asks, any opinion on preterm tube use and differences in nasogastric versus oral gastric tubes? Well, we have treated children with both kinds of tubes. There is not a real difference in development regarding development of tube dependency. So I can't say that the type of feeding tube has an influence on development of tube dependency or oral aversion. I know that some professionals think that a G-tube or back tube or jejunal tube might enhance the oral activity or might decrease the oral aversion of the child, but we did some study on that. My colleague Caroline published something on that in GPGN, and we don't see any differences regarding development of tube dependency and oral aversion. So even if the nasogastric tube has been changed to a G-tube, the children don't necessarily perform better regarding their oral intake. Okay, Gina is asking about her 22-month-old son who is stuck on an NG tube since the age of 11 months, so for almost a year. And she has already attempted to wean him off the tube. Programs we offer, as said, we offer for tube-dependent children, we offer the NET coaching program, where we guide you via our specialized online platform on a daily basis, at 7 days a week, no holidays, no weekends for us. So your child can stay home in its familiar environment, and we give you a plan every day on how the day should look like, how much you feed your child per tube, and we are very successful with that, fortunately. And the second program we offer for tube-dependent infants is a combination of net coaching and on-site approach in our eating schools. So you come to Graz in Austria for 2 weeks for an intensive program each day from 9 to 1:30 and 3:30 to 6. So very intensive, a lot of therapists on our side, psychologists, psychotherapists, occupational therapists, physiotherapists, and psychologists, of course. So this would be the other option. And after these 2 weeks, you are guided via net coaching until your child is tube-free. So I hope this answers your question. Claire asked about our experience in dealing with preterm babies, who is now 8 months old, has left vocal cord paralysis. Okay, and the child is now tube-fed due to aspiration issues. How long does it take these babies to be weaned back after tube? Well, that very much depends on the individual situation of the child. It depends if the child is aspirating only thin liquids or also nectar consistency, because if it's only thin liquids, we can work with thickened liquids in order to wean the child off the tube. If the child is aspirating on all kinds of consistencies, one would need to wait until the situation of the vocal cord paralysis has improved. So this very much depends on the individual medical history of the child. Sarah asks if you could continue to do physical therapy, Bobot and Voiter, while weaning. Yes, of course. You can continue that as long as your child is fine with doing it. The only therapies which we recommend to be stopped during the wean are all kind of therapies which are intrusive in the oral region. So mostly this speech and language So we don't want the children to have negative or intrusive experiences in the oral region during the wean. Laura. Well, the hernia itself doesn't stop your child eating, but of course we have a lot of children with diaphragmatic hernia who got to tube dependent because they weren't simply able to eat before the surgery or afterwards because they didn't feel very good. So if your consultant thinks that isn't the case, why he stopped eating, it's not easy to answer without knowing your child if this is true, but in fact it doesn't really matter why a child got tube dependent. There are so many factors. Prematurity is one of them, but there are so many other medical or psychological problems which lead to tube feeding of infants and children. So that's not, finding reasons is not so important, but one has to work on the solution, on the weaning. Amber asks if the child needs to be at a specific weight or percentage before starting a wean. Well, I know some tube weaning programs have some target weight or height growth charts before they resume a wean. We don't do that, so children must not have a certain weight or percentage before undergoing a wean, because otherwise many children wouldn't be able to be weaned anytime because they simply stay below third percentile all of their life and are underweight during their whole childhood, and especially children who have been born small or light for dateness are considered to stay smaller than the average child. So so we don't have any preconditions regarding weight. Of course, if a child is very malnourished, we would postpone the wean a bit, but if a child is just growing along its own percentile, then we are fine with that. And in some cases, children tolerate tube feeds not, so they have great problems in tolerance of tube feeds, so they vomit very much, up to 40 or 50 times a day. So of course they can't gain weight on tube feeds, and in this case it's even better to start a wean, because most of them tolerate oral feeding much better and even grow better on oral feeds than on tube feeds. So I hope this answers your question. Furthermore, one has to keep in mind that growth charts differ very much from country to country or from continent to continent. So US growth charts are completely different to European growth charts, and of course very, very different to Asian growth charts. So it's not so easy to decide if a child is on growth chart or not. But of course some children never reach the percentiles. James, thank you very much for your comment. Yes, it's great that London is taking all of her nutrition by mouth after 5 weeks. I'm very sorry that your US specialists told you that she wouldn't be able to do this. Obviously, she proved them wrong. Christine, hello. Nice to meet you here. Christine is asking, what can we do early in the wean to encourage and expose the child to taking liquids? As said, taking liquid is the hardest thing from a technical point of view. So a child who is able to drink pure liquids, that's great. But some children simply don't want to drink thin liquids. In this case, one can use thickened liquids, and one must not underestimate the fact that pureed food contains of a lot of liquid. So a child must not take large quantities of thin liquids. Of course, it is important to practice drinking in a playful manner, to use different drinking devices, different bottles. Some children like drinking from the syringe, some like open cups, some like sippy cups, some like bottles. That's a very individual thing depending on the development of the child and also on its personality and preferences. So this is something you must try a lot of things and keep that funny for the child in order to practice. Will you need to, Ian is asking if we need to improve muscular strength before starting a feed reduction wean. Assuming there's hypertonia issues, I think you might talk about hypotonia issues. We treat a lot of children with low muscle tone. So in most cases, we don't have to improve that before the weaning, because even children with a low muscle tone can find a way to feed orally. Maybe it's not solid food, but it's liquids or purees. And of course, also with practice, the muscle tone might improve while feeding orally. Sarah is asking for her child who is barely starting to bring things to her mouth, how would the play picnics work? Well, the play picnics are, for those who don't know, are an important part of our weaning. This means the child gets in touch with food in a playful way, so the children might sit on the floor and play with food of all different textures and tastes. But of course, there are some children who are not able to sit or don't want to touch food. Of course, in these cases, we have to change things a bit. You can also do a play picnic in the high chair, for example. Most important that there are other people around who eat themselves. That's the most important fact. A child who is barely bringing things to the mouth, yet, of course, in this case, one can help the child in bringing things to the mouth, or letting the child smell things, or help with the hand-mouth coordination. Of course, this is possible. So even if the child is still dependent on someone else offering the food, it can give cues if it is fine with what is done. And of course, we don't force the child, but learn to read the child's cues in order to help him or her with eating and tasting food. So we also treat very young children, aged 4 or 5 months. Of course, they are not 100% able to self-feed, and in this case, they have to be fed. But of course, we don't promote any force feeding, so the cue must come from the child, but of course, they need help in feeding by spoon or by bottle or in finger feeding. My colleague just posted the link for play picnics. So if you want to know more about our play picnics, you may have a look on our homepage.